My wife, Michelle. I just got back. I thought it was going to be a little late. I was doing a workout with my son, Joel. He's a basketball player, senior year, and my other son's an engineer student out at Iowa State. So keeps me busy, lots of fun. And chiropractic is a vehicle for you guys as you guys get out there and start doing it. There's nothing better as a vehicle to serve the public. So we're going to talk about the knee today. I can't see you guys when I got this thing on. Can you see that okay, Marcus?
Yes, we can.
Okay. So I'm going to go through the first part. I'm going to talk a little bit about extremities in general. If you don't think that you're going to adjust extremities, I would really strongly suggest you're going to miss a big portion of what it takes to correct people's problems. Very simplistically, if you look at the low back, for example, everybody knows how important the low back and pelvis is to stabilize from a structural standpoint the rest of the spine. We all get the foundation theory, et cetera, but I cannot tell you how many knee or foot and knee problems, acetabular problems, are actually holding the low back from correcting or correcting it as well as you can. So you got to look at the person as a whole. The whole is greater than its sum of its parts and pieces. When we look at finding the subluxation, it depends who you talk to. Dr. Gonstead didn't mind calling a talus subluxation a subluxation. The philosophy guys say that it's not truly a subluxation because it doesn't have the IVF encroachment, etc. I'm okay with that too. They call it a dysfunction. The bottom line is if the knee's not working correctly and that affects the hip, the low back, etc., the body cannot adapt to its environment 100%. And when we look at chiropractic, that's our whole effort, is to remove any interference in the system. And that includes a knee, a foot, etc., that interferes with its ability to adapt to its environment. And so that's where the extremities fit into that. Doc said find the subluxation, accept it where you find it, correct it, and leave it alone. How many on this chat have this book? What do you see, Marcus? They telling you?
I'm pretty sure nearly everyone does here.
And has everybody read it?
Well, unless they lied to me about the chapter challenge.
I saw you guys doing that, so I knew you've been busy. You always start with chapter 5. You guys, once you've read this, then you should give it to 2 or 3 other young students and say, listen, here's a book. This is my gift to you. Start with chapter 5 and then start at the beginning and read all the way through. And then you do it over and over and over. I've probably got... I got 1, 2, 3. I got 3 copies of it right here above my head. And I've got at least 2 or 3 at the clinic. This is my main copy. Years ago, I cut the edge off of it. I laminated the front, and then I spiral bound it. And this has got all my notes in there. And so you'll want a master copy that you keep where no one can ever touch it, and then you'll want another copy you can keep other places. But have everybody get that book, buy that book. I've been through it over and over and over. Here's the system. You guys understand this. Patient history, visualization, instrumentation, static and motion palpation, X-ray, and then which segment. When we say which segment, that can mean knee. Is a knee an issue? And if the knee is an issue, we need to adjust it. If the great toe is an issue, we need to correct that problem to regain functionality of the body so it can adapt. We use all these parts when we're working with an extremity. Patient history is extremely important with extremities. And the nice thing about extremities is it can be simplistic, meaning if the medial side of the knee hurts, they put their finger on the medial aspect of the knee and they say it hurts right there. The chances are that that's the aspect that you're going to be looking at. It's really quite specific, pain point, tenderness. Same thing in the spine. When you get your finger on the bad one in the spine, if it's 7th thoracic and you really work yourself through there and you get your finger up into the edema, the patient will say, that's it right there. It's not that they wince in pain that you're causing pain. They can tell that that's tender. There'll be tenderness under that spinous. Visually, we can watch them walk. We can visualize them from the front side pertaining the knee and the posterior side. You can look for petechia and broken blood vessels at the back side of the knee. back in through here. Swelling at the medial aspect. If they walk, are they kicking their toe out like a PEX tibia, or is the knee opened up on the inside like an AIN femur? Visually, when the patient walks through the door, we start to watch them from top to bottom. So I'll have them walk to the end of my adjusting room and back. And the first thing I always watch is actually their feet. I don't even start with their hips. And then I check their knees, and then I go to the hips. Because if you just look at the pelvis, you may miss, very often you might see a malfunction in the pelvis, something that doesn't look right. But if you look further downstream, there may be a knee involved or a foot, fallen arch. Then I'll look up through the middle back and see which way the middle back's moving. Are the arms swinging equilaterally? Does the head have a fluid motion as the patient's walking? All those things tie into a visual analysis. Instrumentation. I probably won't demonstrate this here with you guys today. Marcus, you guys got any single probes down there?
Well, Steven, are you on here? Can you talk about what you have?
Yeah, here.
Yeah, you want to tell Dr. Lawlor what you found?
So I don't know if you ever heard of it before, but it's a single probe galvanic instrument.
Yep.
It has like let me pull mine because I'm on my iPad right now, so let me just pull it up. Turn the camera on. All right, you can see me?
Yes, we can.
All right. So this is basically all it is. I don't know if you've ever seen one of these before.
Oh, yeah, I have. Dr.
Yeah.
Rod Campbell brought one in.
Yeah, so this
He loves
is... Yeah, so my dad had one. He gave it to me. And I just started bringing it to club to see if anyone else in the club knew how to use it. You know, I know a little bit about it, but not too much.
So explain how you use it.
You basically hold this. This is a galvanic probe. You just hold it in your hand. You turn it on, and then you run it up the paraspinals and right up the middle of the spine, and it gives you can change the resistance on here. So you can see that you can change it. And basically it gives you, the measurement is in milliamperes. So it's pure electricity. It's not heat conductive, like a nervoscope. So supposedly how it works is it gives you nerve interference with the sudoriferous and the sebaceous glands in the skin. So it kind of tells you, like just through the skin, how those glands are working through nerve interference. So if there's any interference, it would give you a break, basically. But that's really all I have.
Does it make noise or does just the needle move? I forget how that one works.
Just the needle moves. Supposedly there used to be ones where it would buzz and make a noise and it would light up. But those ones are long gone. Those are like super old ones that were made in like the 40s and 50s. That supposedly Gonstead used to have, but it was confiscated by the FDA, supposedly, from a story I heard. But
Someone just said Dr. Pam has one. That is true.
yeah,
Here's the modern day version. Can you hear that?
Oh, yeah.
So you explained that perfect, Stephen. This is called an acculocator. You can get these. I think they're only $30, $40. Oops, I had it upside down. PowerMate acculocator. So here's the sensitivity, and what you do is if you connect, here's the one you run on the patient. This is the one that the patient holds. So they hold it in their hand like this, and then you would run this whatever area you're looking at. So for example, with a knee, if I want to check the knee, if I've got problems on the medial aspect of the knee, the main problem we're typically going to find is called an AIN femur. And so that's the one I'll focus on today. But you can also have an AIN tibia on the medial aspect. And so one of the things we need to discern is when we're looking at an extremity, when we look at the joint, are we looking at the tibia side of the joint or are we looking at the femur side of the joint? Another application would be in the low back. Let's say we're trying to determine, do we need to adjust fifth lumbar or the sacrum side of fifth lumbar? you can determine what side of that joint is hot. Is it the top half of the disc? Is it the bottom half of the disc? So the way that this would work, if we were to put this on, so if I hold it and then I touch my cheek, so if you connect these two together, makes noise. And then that light lights up. So if I touch my cheek, it makes that connection. And just like Steven said, the increased sudorific changes and the increased inflammatory process in a nerve, you can actually trace a radicular pain from the arm clear back up into its root. I watched T do that one of the first times I ever saw one of these. He says, well, trace that nerve. It was a radicular pain. It was coming from the spine. And we ran this and it would start to buzz. And if you get away from the inflammation, it goes quiet. And the way that you work with it is you got to adjust your sensitivity up and down to feel that out. And so on the knee, for example, if we're trying to determine, am I on the tibia side or the femur side, if I run this down from the top and it goes quiet, 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 and then all of a sudden it starts to go bzz, 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 and then it goes quiet again, that inflammation is all on the top side of this joint. It'll get more and more inflammatory or make more noise as you're coming down, and then it will go quiet. If I come down and it's quiet, 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 and all of a sudden it goes bzzz, and then it eases off, then we're looking at the bottom side of the joint. Another example to use something like this would be on the SI joint. You're all familiar with the SASIN rule down there, Marcus?
Yes, we just had club on it on Monday. So.
Okay, so one other check you can do, if all your findings, if you lay the patient down and the leg pulls shorter than you expect to see based on the X-ray, you would say, okay, it's the rotated sacrum pulling that leg short. Even though it doesn't measure 6 millimeters or more, because it pulls that short, I know it's on the sacrum side. Well, you can also take this and run this from the ilium out into the SI joint. And then once you get to the sacrum, it'll get hot on that side of the joint. If you come from the sacrum, it'll go bzz, 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 bzz. But once you cross the joint, it'll go quiet on the ilium. Versus if it's the ilium problem, it'll do the opposite. It'll be hotter on the ilium side. So what Stephen was talking about on the spine, when you're going up and down the spine, does that do us any good with just one probe going up and down the spine? What do you guys think?
Probably not as good as two.
Edgar, what do you think?
Can you repeat? Sorry.
So if we're running this up and down the spine and we're checking up and down the spine, but we're only using one probe, does that do us any good instrumentation-wise versus running a dual probe?
It doesn't replace it, but it could be an indicator still.
Right. Remember the discussion we had on cord pressure?
Yeah.
What do we do with cord pressure? We camber the scope.
Yeah.
And essentially when we camber the scope, what we're doing is now we're differentiating and we're reading nerve above to nerve below. You can do the same thing with this. So this is really fun. This probe here, instead of running that on my cheek, if I turn the intensity up, I can actually just hold that in my hand, and then I can connect on a patient. I could connect with my finger. So if the patient was holding this, I can actually connect this, and I can use my finger to trace that. It'll connect right through me. It's all about connectivity. So Dr. O'Hara will take a dual probe. I don't have mine in here, but he'll take a dual probe and he makes what he calls a unicorn. So he'll take the dual probe and he'll put his finger over one probe. And then he'll take just one probe and put it right on the spinous on one side or the other. And his body temperature is close enough to the patient's body temperature that the needle on the dual probe will start to read. And he'll run that down. And what's he doing? He's comparing level to level to level. Follow? So there's all kinds of ways that you can start to look at your instrumentation to find where that pressure's at. That's the most important question that a chiropractor can answer is where is the problem? It's the most difficult part. And Gary Pfaff, he used to talk about Dr. Gonstead. I was asking him about all these different things. And he said, like running the scope in the pelvis, for example, I said, did he ever go like run it in the SI joint? And Gary Foss said he ran that damn scope all over the place. He'd be out on the outside of their SI joint. He'd run it down the side of their neck. You know, he was trying to figure out where that pressure was at. So as you guys go through the chapters, 99% of what you guys do every day is the basic stuff you're learning in club and what we teach you at the seminar. But there's that other 1% that you got to think like a doctor and work through a problem, be a problem solver. And that's where the system of Dr. Gonstead that we were just looking at is so extremely valuable. Questions on single probe. That's just a preview. We could do a whole class on that sometime. Simple enough?
Do you normally use more for extremities than spinal?
Single probe, yeah.
Yeah.
Yeah. Once in a while, I'll get it out and play with it on the spine. And typically, that's more to entertain myself than anything. But on the extremities, it's really valuable. You know, and honestly, I don't run it on all the extremities. You know, if it's something's clear cut, I take an X-ray, I palpate it. The pain point's right where I expect it to be. It motions that way. I'm going to fix it. I don't run a single probe on every single extremity I work on. Should I? Probably best practice would be. That would be one extra thing to go, that's the correct one. But if I've got a case I'm trying to figure out and work through and go, okay, is this really coming from the knee or is this coming from the hip or the low back? You know, then I would definitely get the single probe out and work through that.
And do you ever use it, like you said, for the sacrum versus ilium situation?
I did for a while. I haven't for a bit, but I'll run my dual probe down through there. I'll just run my dual probe both sides and see which way that needle will break.
Okay, gotcha. Thank you.
I do that pretty regular. Again, that's not something I do on every patient. If everything's matching up with the basic analysis and I'm like, okay, that's an external ilium, boom, 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 I just go fix it. But if you're looking for that extra piece of information, I may do that with a single probe. I may do it with my dual probe. I may get them up and walk them again. I may take them over to the high-low, lay them prone and pick up the back leg just a little and palpate it that way. You know, you start working through a number of different options. I may run the Titron on them, fix them, go run the Titron on them right away again. So those are all additional things that I'll go to if I'm trying to work through a case. I've got a Titron that I don't run on every patient, but I've got patients that I run the Titron every single time because they're that kind of a case. So again, Fred Barge, his big thing was always, you're the doctor. And that's, you guys are going to get far enough down the road where you got to take some leniency and figure cases out. And the more you start thinking like Dr. Gonstead, the more you'll start to get results like he did.
Thank you.
Hey, Dr. Lawlor, quick question.
Yeah.
Have you run into a scenario where you use the single probe and the dual probe on the same patient? Like you found the single probe showed something on the knee, and then you ran the dual probe along that area as well on the spine and got a break there. How would you handle that situation?
Who's talking here?
I don't know, me if
Steven.
you can see it.
Steven.
Yeah.
So how would you handle that situation?
First thought would be stick to the spine always anyway.
There you go.
Okay.
So if it's a new patient and you gave me that scenario, which I had a case just like that, it's a shoulder case, an older woman, and I've only been working in her spine. I've seen her 3 times now. I took X-rays of her shoulder. I palpated the shoulder. I got everything figured out what I would adjust, but I'm only working in her spine. I can add the next one down the road, but basic scientific experiment is always to eliminate variables. Right. So let's say you've got a 7th thoracic, 2nd thoracic, something that palpates as a PS shoulder. It's got the pain point for a PS shoulder and a right EX. And their main complaint is shoulder pain. Well, right EX could fix a left shoulder problem. But if you fix the right EX, the T7, the T2, and the PS shoulder, and she comes back worse or better, you don't know. Right. So my rule of thumb is always less is more. And in that instance, start with spine. Unless you check it and you're like, you know what, this is totally a knee problem. Even if I fix the spine, this knee problem is not going away. Then you can fix both. Okay. So it's always better just do one thing at a time. And then as things change and evolve, then you can move on.
Cool. Thank you.
Do you notice that when you're doing one thing at a time, if the patient's not responding and you've tried other things, but only one thing, would you go towards doing 2 different segments for one problem? Would you ever do something like that if you notice that maybe they need both done at the same time?
Absolutely. I do it all the time.
Okay.
But typically, if I'm trying to figure something out, I will reduce my variables. But once I've got a case figured out and I know that a knee is important, I know L5 is important in 7th thoracic, I'll fix them all. I don't have any issues with that. Now, I don't go fixing Atlas, C7, T7, L5, right knee, left hip. None of that. But as long as you follow and what you're doing is criteria specific, generally speaking, Dr. Gonstead would adjust 2 to 3 segments. Generally speaking, on acute cases, he would almost always try to limit to 1. If something was parasympathetic or sympathetic specific concerning a chemistry or visceral, you stay system specific. But if you don't have a chemistry problem, for example, you can fix an internal ileum and T7 same visit and get really good results.
Okay. Yeah. Thank you.
Yep. Good question. All right. Dr. Gonstead said be Pacific. He would always say, he'd leave the S out. He'd say be Pacific. But the more specific you are, the better. Same is true with the extremities. Why do we adjust extremities? Many joints in the body offer, other than spinal joints, can be subject to loss of articular juxtaposition, which can interfere with normal transmission of nerve impulses, be it directly or indirectly. I use the example of a knee problem causing a low back problem. Dave Geary told me a story one time. He says, I had this case come in. It was a constipation case. It was a young boy. And I fixed and fixed and fixed, and I could not figure it out. Fixed everything I could find in his spine. And so one day he came in and I checked him, and he actually said his knee was bothering him. So he laid him down, checked it, fixed a posterior tibia. And guess what went away? Constipation. Boom. And there's no nerve in the knee that we can explain that with. But biomechanically, you can totally understand how that knee will affect things above it. So we got to regard the body as a whole. Subluxations that produce pain and dysfunction must be corrected. Now, ask yourself, what's the cause of the extremity problem? This is a good example. Here's a classic severely degenerated disc, D5, D6. Is the spine an issue in this case? For sure. So in some situations, the patient may have knee pain that is fixed completely by addressing the low back. The number one cause of extremity problems is spine. But when the extremity becomes a problem, now you need to address it. Here's another good example. Look at the normal foot here. Look at all these joint spaces. When we look at an extremity X-ray, we always want to look, are the 2 bones that create the joint, are they in proper juxtaposition? Meaning we have a nice equal space all the way throughout that joint. That's key. Here you can see one starting to slide off. That may be the angle, or it could be the bone. You would have to check it. But if you look over here, this is what a gouty presentation of a toe would look like. I'm sure you've seen that in class, but if you've never checked one, they will be hot. And if you try to adjust this thing, the patient will not be able to walk for a week. Gout is not an extremity problem. That's a spine problem. And you can help these people a lot, very often from like T5, T4. Now, if you look here, you can see the misalignment. You're going to find in this instance an open wedge here and an open wedge on the outside of the bunion here. Dr. Gonstead taught us to fix both problems. Fix this problem first, this problem second, because this is the major problem. So the rule is, anytime we were talking about could you fix more than one bone, the rule is if you've got a problem in the spine that's more important than anything else, let's say, for example, L5 is actually the patient's most important bone from a big picture. As far as you can determine as a chiropractor, that's the most important. But you want to adjust T7 and the right knee and L5. Well, start with the knee, fix the knee first, then fix T7, and finish with L5. Reason being, the less we do after we fix the most important one, the less we will disturb it by adjusting anything else. It's one of the great benefits of adjusting less segments. The less you bother it and allow the body to heal, the better the patient will do. That's why Dr. Gonstead was not a big fan of therapy. He played with some of that stuff, therapy and exercise, but he said it was too much impulse input into the nerve system. So here's an example where the extremity is the problem, and this needs to be addressed. Now, you may get this toe functional with a number of adjustments where it is no longer symptomatic. You will not get rid of this deformity. They're always going to have that bump and deformity. There's no correcting that. Now, you can reduce that over time with good care and very often a good orthotic. Once it gets functional, it doesn't need to be adjusted each time you check the patient. You may check it, but you may stick your thumb down underneath the here, and when it's subluxated, it'll be tender. They'll go, oh my gosh, that's terrible. But when it's not, you let it alone. You don't fix it just because it looks bad. 4 main considerations. Rule out the spine as the source of the problem. Number 2, rule out fractures. Number 3, rule out severe tendon or ligament damage. So if you get a patient comes in and they're 25 years old and they completely rupture their ACL, that person needs to go see an orthopedic. They're going to need surgery. And lesser tears may need orthopedic care. But generally, the one you're looking for is the complete tear. Now, if you get someone that's, people live with full ACL ruptures all the time. So if you get someone that's running a sedentary life, et cetera, and they don't want it, they can do fine without that. But if they had to run from a bear down a hill, the chances of that knee giving way on them are much higher. So a full rupture, you got to send out. We take films, we always take them in 2 views. Now, in all disclosure, we should x-ray every extremity that we're going to work on. However, I will tell you, and many chiropractors will tell you the same, people come in with a thumb or a lunate or a radius, an AI shoulder. We'll fix those all the time based on our analysis and checking it. And they're what I would call a run-of-the-mill adjustment. You'll run across those. So I'm not saying that I won't adjust an extremity without an x-ray. However, best practice, especially early on until you get really good with your hands, take some films, especially the knee. I always take films when I'm taking care of knees. I'll check them, I'll look at them, and I'll even feel them out, but knees are joints that I'm going to take an x-ray on. You get a lot of information off of them. We want to take 2 views, 90 degrees in opposition, and then we want to look to see, is that joint space equilateral across? And we're going to look at some knee films here in a little bit. Tuning fork, what do we use a tuning fork for?
Fractures?
Fractures. If you put a tuning fork, let's say there's a fracture, let's say they broke their 5th metatarsal here, common fracture. I got a lady that's got a really bad joint here. I think she either got a fracture in there or got it infected. She's been to the orthopedic 2 or 3 times. And I had her 75% better, and then she drove back to Pennsylvania for a wedding, and she danced all night long. And I have not been able to get a hold of it since. So I took another set of films. I can't see any fracture, etc. I just really think she's got it all torn up and irritated in there. But if there is a fracture, one of the things I did was I took my tuning fork and I whacked that thing on the edge of my chair, get it vibrate, and then I stick it on that bone right there. And then I do the same thing and I'll stick it on that bone right there, and then again down here and right in the middle. If I'm suspecting potentially a fracture in this area, I'll check all through that bone. What is the response to someone that would have a fracture? Let's say they got a hairline fracture right here. What would their response be?
Very painful.
Yes, they'll sit right up in the chair. You put that on there, they'll go like that. I mean, it's if you've ever had cold air hit your tooth just wrong and you're like, holy cow, or you bite into ice cream, for example, and it gets real cold and it hits a nerve, so to speak, it's that kind of a response. And it's actually more sensitive than an x-ray with an early on fracture when the swelling might hide it on there. So that's a very good practice with extremities. Subluxations of extremities usually have localized pain and more edema. The fractures have a more generalized pain, and many times there's a bubble of swelling over the fracture. So the last one that I had come through was a guy that fell on the stairs, snapped his ankle, and he broke the lateral aspect of his fibula. Common fracture. But his tenderness was all the way down. He sprained his ankle as well. The whole ankle was swollen. So just the whole thing was generally swollen. But once you went in and put pressure right on the fibula, I didn't have to use a tuning fork. He'd about climb off the chair. And so you go take an x-ray and the thing was busted. Once the swelling comes out of there, then they can still have more generalized pain throughout that leg and ankle, but it's the fracture and they're doing it. Where if it's the ankle itself, they'll point, for example, to the lateral aspect of the talus or the posterior aspect of the calcaneus or the bottom of the arch where the navicular would fall. It'll be more specific. And then when you palpate it, you'll find it with your thumb. Fractures have disrupted periosteum, which will make moving the distal portion of the fractured bone painful. Use a tuning fork. So when do you need surgery? There's a time and place for it, guys, but you'd be surprised. I was going to take a picture, bring an x-ray. I didn't have time to get it done, but I have a 96-year-old right now. No, he's 92. I have another guy's 96. He's 92. He had a terrible shoulder, and I worked on it probably 4 or 5 years ago for about a year and a half. There's just no joint there. He had terrible pain. He couldn't sleep, and the range of motion, this was it. He couldn't move it at all. And the joint, when you take the x-ray, there was nothing. It was literally bone on bone. But the trick was he didn't want to go to the surgeon. He's like, nah, I don't want to go do surgery. I don't want to go to the therapist. If you can help me, I just need to get out of this pain. So I started chewing away at this thing with him. And sure enough, slowly and surely, the pain started to come out. So I got it. So his range of motion was probably, 20, 25, 30% of what normal would be. But he didn't have any pain. He was happy as a clam. Then COVID hit, and I hadn't seen him for a year. And he came back. His daughter called and said, I got to bring my dad in. His shoulder's bad. And she says he fell. So what happened was he fell on his arm outstretched. And when he fell and landed, it jammed the humerus up into the scapula. And it separated his clavicle. So the clavicle was separated, and the ball of the humerus got jammed up into the scapula, and it made the ball of the humerus got flattened out like this. So he had a fracture, but there's no fracture on the neck. And he'd had this for about a month before they brought him into me, and the shoulder still it was bright red that's under the skin. Like, how bruising will get purple and yellow and be healing. His was still bright red, so I could tell there was still an active bleed going on in there. So I took some x-rays, et cetera, and I showed him the fracture, and I showed him the separation. And again, I asked Grandpa, Russell's his name, what do you want to do? He's like, well, you've helped me before. If you can help me, then that's what I want to do. So my big question in that particular instance was, I had his daughters there, so I talked to them and told them what my plan was. I didn't see anything dangerous about it. I told him the only exception is if he were to fall again. And he did. He fell a second time, but he didn't get hurt any worse. But if he fell again, I said, if he jams that further up in there, it'll make a mess of it. But his option of going to the surgeon, the only thing they'd do is painkiller. He didn't want to do that. He says, no, I'll deal with the pain. And potentially maybe they would have tried to replace that. I don't know. They might have tried to fix the separation, but he didn't want to mess with any of that. So I adjusted it. I strapped it down, put him in a sling for about 2 weeks, and I kept adjusting about every 4 or 5 days. And all I did was just real gently, instead of setting it as a PS or an AS, I just gently distract that down, and then I'd bring it forward a little bit and back a little bit, just to get that bone back out of the scapula and let some fluid up in behind there and let it start to heal. And I just kept doing that every few days. And within about 3-4 weeks, the pain started to drop down, and now he comes in, he don't hardly have any pain at all. So for you guys, when you're looking at whether or not to send to surgery, don't take care of something you're not comfortable taking care of. Don't be afraid to share the responsibility. That's an important rule as a young doctor. And the first question you always ask is whatever I'm dealing with dangerous? If you, like I took a blood pressure on a patient early in practice, was 260 over 160. And that got my attention quicker. I'd never seen one that high. And so I told him he had to go get checked and all that. And the thing turned out fine. But I also had another guy come in one time, and he had severe pain. Collapsed on my front desk. He thought he needed an adjustment. He was an old-time patient of T's. and the guy was having a heart attack. And so we sent him out right away, called the ambulance, and within an hour he had 7 stents. And he'd have died right there in my office, I think. I'd never seen anything like it. So, number one question, is this dangerous? And if it is, you send him out and get some help. Always err on the side of caution. Having said that, the further you go, the more you get used to dealing with things. Compression fractures, herniated disc, broken shoulders. It's amazing the things that you can work with. So don't be scared, but reach out to some people. Get several sets of eyes on it. So like the guy with the shoulder, I sent an email to a few docs and said, this is my thinking. This is what I want to do. Do you see anything that's dangerous, number one, or doesn't sound just smart to you? And they sent back, nope, that sounds good. Don't forget to do this and this, and away we went. So use your dream team. When you're trying to figure out what's right or wrong, reach out to your colleagues. You don't always have to send them out to a surgeon first, an orthopedic. Reach out to us. And if I don't know, I'll forward it to some more people. Right now I got an inbox full of emails from today just alone. Probably 3 or 4 would be from doctors or students. All right, there's your knees. Classic view. This is the one you'll use the most from a listing perspective. Just basic anatomy. You got your femur, patella, tibia, fibula. When we look at the knee, this one I just noticed does not have a marker. This should be right here, the right knee. This one here should be the left. So the knee x-ray is the one x-ray that we don't look at from behind. So that the x-ray of the spine we look at from P to A, because when we're behind the patient, scoping our patient, behind the patient, palpating our patient, then we can look at the x-ray, and we're looking at the x-ray in the same plane behind them as we are when we're evaluating them. Well, with the knee, what you do is you walk around to the front of the patient and you evaluate them from the front, and that's why we view the knee in a different form. Causes of knee trouble: spinal subluxations, T11 through L3, ilium subluxation can change the shaft of the femur angle, leading to an uneven meniscus wear. IN major can cause medial knee pain. Foot problems, pronation of the foot where the arch falls, can cause a medial knee pain. In that note there, the common thing you'll see is a fallen navicular, an anterior medial talus, PS calcaneus, and then you also see the AIN femur. They kind of all fall together. Overweight, that's a common one, and it also causes those problems that I was just talking about. Chemistry imbalance can have similar pains bilaterally. So think adrenal glands very often. If they've got pain in both knees, if they've got pain in both knees and both shoulders, think spine. Extremity problems will most times present unilaterally. And then trauma. Always get a good history. If you have someone that wants you to check their wrist and they fell with their arm outstretched or this or that, take an x-ray. Trauma, x-ray, trauma, x-ray, trauma, x-ray. All right, questions so far? None?
There's one in the chat that says, do you go off palpation or x-rays more for your listings?
Who's asking that, Dr. Marcus?
Sophia.
Sophia, what do you say?
Might be thinking for a sec.
That's all right.
Palpation, she said.
Good job. So you're thinking like a chiropractor already. We always go off what we find on the patient. We talk about that with the spine a lot. Now, can you look at an x-ray? Let's say we all sat down with Herb Wood and had him go through 10 x-rays with us and asked him what he thought if we gave him the patient history and had him look at the x-ray. Do you think Herb could pick out with a pretty high percentage of the time the bones that probably need to be addressed?
Yes.
Sure he could. Yeah, he's got the experience. He's done it thousands of times. So you can, that's the beautiful thing is a lot of times you're stumped. You're like, God, I can't find nothing on this. I don't know what the hell's going on. Well, go study the x-ray for a half hour. And after you study the x-ray for a half hour, you finally go, you know what? The The sacral base angle is 35. L5 is a 13-degree disc. It's noticeably posterior in the IVF. I'm going to go look at that thing again. And on the X-ray, I can see it's got a small spine. Just go down there, re-scope it, dig your finger in there, palpate around, and you'll be surprised what things will pop up. That's the beautiful thing about an X-ray. So we always find it on the patient. So I'm going to show you here, Sophia. I want to just show you a video here. We'll get back to these in a second. But this is an example of an AEX tibia that I'm adjusting, okay? So the pain point on this particular patient's lateral. Anytime that the pain's on the lateral aspect of the leg, I want you guys to think tibia. Anytime the pain is on the medial aspect of the leg, I want you guys to think femur. Now, the more common of the two tibia listings is PEX. In this instance, I'm adjusting an AEX tibia. Now, if they've got pain behind the knee or pain under the kneecap or front of the knee, suspect either a superior patella or a posterior tibia. And we're going to go through those some more here in a minute. And I'll send these notes to you, Macy, so you can send it out to the group, okay? So this one rotates forward pretty well, posteriorly, not as well. So, Sophia, what I was doing there is I'm palpating the spot within the meniscus. So if I'm going to palpate on the lateral aspect here, I'm going to palpate right in through and around that meniscus. The subluxation can occur anywhere around that space here. So I'm palpating statically, one, to find the bad spot. And just like in the spine, when you palpate down the spine, you'll find a pebble. You'll find a spot right in that joint, and the patient, ooh, that's tender. And you'll feel it. You can roll it under your finger. It almost feels like a little pea in there. That's the spot you're looking for. From there, you're going to motion the joint. And what I was just demonstrating there is when I motioned that joint forward, it felt okay. But when I tried to take it posterior, it felt stuck or restricted. So that told me that the tibia is external and it's forward. So I'm going to take it back just a little bit before I set it. And then I'm going to set it back into the joint this way. See, I'm turning his posteriorly, not as well. Turning his foot down here and feeling it there. Side, same thing. Lift it up into the joint. A to P. This arm brings the foot towards me just a little bit to take the slack out, and then set, but only set with this, not with this. Very good, Steve. Thank you. So there's an example of the end product of what we're going to talk about here in terms of figuring out what to adjust.
Hey, Doc, do you always use that block there for your knee adjustments?
No, I do not.
Okay.
But if you're asking, should I all the time, that what I just showed you is the best way to correct a knee problem.
Okay. That's extra stabilization, really? Yes.
You can control it so well. Number one, the patient can relax so well. Number two, and you can turn the femur. It's by far the best way to fix something. Now, most knees and things that way that you're going to fix, AIN or PEX, you can fix them in the chair just fine. They're always better if you can have someone stabilize for you. So I'll show you a few more of those. But if you don't have a block like that, Marcus, you guys got blocks like that down there?
No.
So you can make these. One time, all you got to do is just a nice half moon cut, so to speak. And then this is styrofoam. So you just take a chunk of styrofoam and you cut that, and then you take a little saw blade, you draw your line, and then you just cut that out of there. And then you take a little piece of foam, and on this one it's probably a 1/2 inch, and you cut that and you glue the top of the styrofoam. You stick the foam in there, and then the ones that I made, I never even covered. This has got a nice little piece of fabric around it. You can do that. But I made probably, back when I was an intern, I bet you I made 100 of them. We used to take them to the seminar and give them away. And all I did is it was a foam block. Literally, mine were pink, just like what you'd put like for insulation in a wall.
Oh, yeah.
And you get those big 4x8 sheets. You make a bunch and, sell them for $5 at the club there, and you make a killing. and then just a little fabric, and you glue it in there, and you're good to go.
And also, do you ever use torque when you're doing that adjustment to try and close that wedge, or is it more just a lateral to medial on that exact one?
It's torque. You can think of it as torque. Sometimes you turn it up and in, but what I want you to think is arc.
Okay.
You arc it back up and through the joint. So you can do that by torquing, or you can do it by the way that you put your elbow as you're leaning into it. Just like lifting a fifth lumbar, you can lift it in an arc, and then you can torque, whatever you want to do.
Okay, thank you.
You arc it into the joint.
So, just what were the contact points on this one? On the one you showed, the AEX?
This one rotates forward. So right here, can you see this model, Edgar?
Yeah.
Okay. So here's the medial aspect. Here's the lateral aspect. Yeah. You want to be right in this area, and you're going to contact. In this case, since it's anterior, you're going to contact a little bit toward the anterior portion, and you'll be in front of this lateral collateral, and you're going to contact the lateral portion of the tibia and the meniscus. The block then is set up on the inside of the knee here. So we want the block to stabilize the femur so we can set the tibia. Can you see that clear enough?
Yeah.
Okay. So that's your contact point. The reason that it's important, and that's a key point with the knee, the meniscus, remember, is intricately tied to the tibia. The articular capsule of the femur, that thing just moves on top of those meniscus. It's not tied into there. So in the adjusting room, if I have an intern, if I'm fixing this in the chair, I'll contact here. I can either use a thenar or I can use a piezoform, but then I'll have an intern come around here and they stabilize the femur. But I don't want them on the meniscus. I just want them to hold the femur, so I can slide the tibia and the meniscus back under the femur.
Yeah.
Make sense?
Makes sense, yeah.
That's a key point with the knee right there. You take that home and it's winter chicken dinner. All right.
Dr. Lawlor, does that apply for every tibia adjustment? Are you always contacting the whatever aspect of the tibia and the meniscus?
Yes, it does.
Okay, thank you.
So that's why when we talk about a PEX tibia, if you look at the anatomy, the lateral collateral and then the fibula here, it gets a little more difficult to get specifically on that point. So you can do a PEX tibia just like I was showing you there, but a lot of times a PEX tibia will rotate posterior like that, and so we'll set that face down just like what we do when I show you the posterior tibia here in a little bit. Very often a posterior tibia is also actually a small PEX tibia. There's almost always a little bit of EX with a posterior tibia. Not always, but a lot of times. So motioning the knee. The doctor and the patient should be sitting. The doctor should be sitting on the medial aspect of the knee. Now you can do this one of two ways. You can sit on an exam stool. The best way to palpate the knee is actually to get down on the floor in front of them, have their knee what do I want to say, when they're sitting in the chair, you don't want their knee straight and you don't want it bent all this way. You want it just kind of in a loose posture, and you can kneel in front of them here and then palpate. And I hold their foot with my knees. I'll actually pick it up just a little bit and I hold it with my knees. And now I've got the joint of the knee in a loose posture. The other way you can do that very readily is have them lay supine. Have them lay down on the pelvic bench. And sometimes if you put this block just underneath the knee, that gives just enough bend to loosen the knee so you can palpate it nicely. You don't ever want to adjust the knee or palpate it for that matter locked out. What you're going to do is you're going to palpate the joint space at both the medial and lateral aspect, checking for bulging and tender meniscus. So very simply, the fabulous thing about the knee is it's a simple joint. If everything's lined up correctly, no issues. But if you get a PEX tibia, if you get an AIN femur, anything that changes the way that these ligaments the medial collateral, lateral collateral, posterior cruciate, anterior cruciate, it changes the way that they are designed to function. And you're going to start to have trouble. And depending on which way it goes is where you're going to feel that bulge around the meniscus. So check the lateral aspect and check the medial aspect. What knee listing is the most common that we run across?
AIN femur.
Very good. Who said that?
Brittany.
You get a gold star, Brittany. Then you move the legs side to side to check for a wedge. So very simply, when you're sitting in front of him, you're just going to hold the knee and you're going to stress it in and then out. And just see there should be a little bit of give both ways. Now, one of the things you'll feel a lot of the time is you might move it this way and it might go a ton that way. But then you come this way and sometimes you'll even almost feel like it clunks. You can feel that it's what we would call sloppy. Well, it probably is sloppy. There's probably an open wedge here and this ligament has been stretched. So that's a key that if you find tenderness around this joint, that we need to set the femur back that way. So whichever way the bone won't go, that's the direction we need to set it. The joint will not close down as much on the side of the open wedge. This open wedge, when we start looking at the X-ray, probably Doc could have worded this a little better. I would say on the side of the problem. So you can have a meniscus that's starting to thin and wear out. Okay, so that when we draw those lines, that may actually be thinner. But can you have a thin disc that actually is bulged and swollen? Yes, you can. But it will still look thinner than the other disc. So the real key on this one is the tender spot on the side of the problem, because you can have where it looks wider on the outside, but it's actually the inside where it's thinner that may need to be adjusted. So don't get confused on that. It took me a long time to understand that. I'd be working on a knee and T's like, well, check the other side. And I'd feel it. And I say, yeah, but T, the lines are like this on the outside of the tibia. It's opened up. He's like, yeah, but the problem's in here. I said, well, yeah, but the lines are like this. Well, he didn't care. He wanted me where the problem was. So just what Sophia was asking, always go with your finger, Sophia. Find it where it's at on the patient. Introducing rotation to the joint will reveal more movement on the side of rotational misalignment. There will be approximately 10 degrees, both internal and external rotation in a normal knee. So, for example, if we've got an AIN femur, so here's the internal side of the femur. That's the problem side. That's where the internal comes from. And it's rotated anteriorly. If I rotate this anterior, there will be more motion that way because it's already stuck there. But if I try to take it posteriorly and then I challenge that joint, that's where it will feel most stuck. Did I lose anybody there? Sophia?
Would you ever have a situation where you have an AIN femur and a PEX tibia?
Yes.
Where you need to address both?
Yes.
Is that just a severe kind of, like they got wrecked in football or something? Like, or is
No, I wouldn't say that. It's not a high percentage of the time. If I was going to put a percent on it, it's probably 25% or less. Okay. Most times it's going to be one side of the knee that needs to be fixed.
So is it just both findings are there on each side? Like it's tender on both sides. It's when you palpate the tibia side of the disc, it's not moving well, and the vice versa. Okay.
And then generally in those situations, Marcus, what you do is you fix the tibia first, and then the fibia, and no more complex than bottom and then top, because you want to set the tibia with the meniscus and then finish by setting the femur back on top. And in essence, we almost do that when we fix an AIN femur, because we're stabilizing the tibia and we're setting the AIN femur to the tibia. Doc just found that the way people respond the best is when you follow the notes we're talking about here.
And you do one at a time. You don't try and knock them out.
One at a time. Yep.
Thank you.
So I would set the PEX tibia. I have the intern stabilize the femur. I'd set that, and then I'd come around the other side, contact the femur, have them stabilize the tibia and the meniscus, and then set that.
All right, yeah, I was asking because we've heard a few docs around our campus say you could just set them both at once just to do less, like not have to do 2 adjustments. So I just wanted to kind of clear that up. So thank you.
Yeah, no, you want to set them one at a time. X-ray positioning for the knees, 72-inch film focal distance. Mark the bad knee with a BB. So you just take a BB with a piece of Scotch tape, tape it right where the pain point's at. So typically you're going to see that little BB on the medial aspect of the knee or the lateral aspect of the knee. It's a weight-bearing X-ray, standing position with feet 90 degrees to the bucky. So that's unique to this X-ray. If someone's got a right foot flare could be an internal ilium pulling the foot out, but it could also be a PX tibia that can do that. Or if it's a lot flared, you could have an internal ilium and a PX tibia or an AIN femur. So with the spine X-ray, we leave the foot flare. We always make sure that they're lined up front to back, but we don't correct the foot flare. With the knee X-ray, we're going to correct that. We're going to take the feet and put them straight ahead, because what we're wanting to do is we're wanting to compare this bone to this bone. We're not worried about changing what's going on with the ilium. We only want to look at what's going on with the knee. And so that's why we take the flare out. We're going to lock the knees, and then we're going to take the view. Measure the center of the upmost femur shaft. Mark the center of the patella. Connect the dots to form the femoral shaft line. Measure and mark the center of the inferior-most tibial shaft, and then the center of the intercondylar eminence. Connect these dots, and that's the tibia shaft line. I'll show you all these in a second here. Plane lines, draw a line across the condyles of the femur and the tibia. The open wedge determines the sign of laterality. Now this is just for listing the X-ray. It's just determining laterality. Again, you could be on the thin side of those lines in terms of what needs to be fixed. That does happen quite a bit. Femur is listed with the medial open wedge, and the tibia is listed with a lateral open wedge. So the way I want you to think about this, guys, is just like if we list the side of body rotation and it lists as a PIX on the right ilium, does that mean we can't adjust the left ilium? No. In fact, we adjust it maybe 35% of the time. So think of it that way. The tibia is listed with the lateral open wedge. Rotational listing for the femur. Now, I'm going to give you all these listings, but just for simplicity, I'm going to focus on the AIN and the PX for the tibia, AIN for the femur, PX for the tibia, because they're the main ones you're going to find. And once you get in your head how all this fits together, you will find those other listings. That's when it gets kind of fun. I had early on, probably one of the very first AEX tibias I figured out was a young gal. And she walked, and when she walked, she had one tibia that was toe in a lot. And both toes were in a little bit. So I thought, okay, great. I got a sacrotubercle. I got that figured out. Well, she was a dancer, and her knees were giving her fits. So I got the sacrotubercle figured out. I was checking her knees. She had Osgood Slaughters. So I was fixing Osgood Slaughters. Remind me at the end, Marcus. I'll tell you guys how to fix that.
Yes, sir.
So I was fixing Osgood Slaughters, but I still couldn't get the knee figured out. And so when I finally watched her walk one day, I'm like, God, I've been doing external tibia. That's where the pain point's at. But that toe is in more. So to make that toe in more, it actually should be rotated anterior, not posterior. And by God, that's what it was. And you talk about a eye-opening experience for me. I changed that one simple thing. I was probably doing PEX. I don't even remember, to be honest. I know I was doing EX tibia. But I went to an AEX tibia, and I started adjusting that side line. Boom. She went from improved to she's better. And it was fast. And that amount of torsion on the tibia is what was putting the stress on the insertion of the femoral muscles going down into that tibia. You know, that's all Osgood Slaughters is. These big old muscles come down and they insert here just like where the screw's at. Well, basically that bone starts ripping away. And you see it a lot with young people because the growth plates are still growing in there, but that's a fracture. And so the only way you can do that is with extreme stress to that joint. But even with extreme stress, if that was the cause, all children would get that, and they don't. that's where it lies for us. So the two things you got to do there is one, fix the pelvis for sure. Two, fix any misalignment of the knee. And then three, fix any nutritional deficiency. So guess what young gals do terribly wrong? They eat horrible. And this little lady, she's about as pretty as you can find. I mean, if you wanted a date to prom, she'd be the girl you'd ask. However, her diet, her idea of eating healthy was chicken breast, broccoli, and ramen noodles. And that was her diet. That was all she was eating. There was no variety of nutrients. So she was actually, although you'd look at her and go, she's a very healthy person, she was nutrient deficient. She was starving, just like someone that's 100 pounds overweight. Even though they're 100 pounds overweight, they're actually starving because they're not putting the nutrients in their body that they need. So you fix those things, and since I'm there, what you do is you take that tibia. I've got recordings of fixing her. I have to find those for you. But you take the patient, you put this block under the knee to stabilize the knee. You're going to take an S to I tissue pull, and you always take an X-ray because you'll see that separation. You'll see the fracture right on the X-ray. And if you put your finger on there, it'll be hot as a hornet. And you take that tissue pull S to I, and you take a gentle piezoform, and you stress that down and set it. Just gentle, just gentle. Once you set that, you need to have, for example, I would have Dr. Brittany come in the room, and she'd be standing right there with a piece of elasticon tape. And what she would do, as soon as I set that down, she'd come right above my hand, right here, and she would take that tape and stretch it, and she would pull it down around the sides, and we'd strap that down the leg. And then we would pull the patella down, and we would strap the patella down with some elasticon tape. And we do that, put her on some calcium lactate and Cataplex F for about 6 weeks, keep her off of her activities, and boom, that thing would heal up. But if you don't get serious with that, I guarantee you nobody else will. The way that everybody else manages that is horrendous.
So, Doc, you're contacting the superior pole of the patella for that when you're bringing that down for Osgood Slaughters?
I can't see myself when I'm trying to show you these guys. So if I'm not showing you, you yell at me. So I'm contacting right here where the tendon ties into the tibia.
Oh, okay, on the tibia.
Yeah, this chunk of bone gets pulled away. And you'll see that. So like this little ridge you're seeing here, basically you can see space. That just goes, and it's sitting there. It'll be open. So you're contacting right here with your piezoform, and you're going to approximate it back to the tibia. That's all you're doing is approximating it to the tibia. And then you're going to strap a piece of elasticon here and stretch it down and strap it down into the front and back of the calf. And then you're going to stretch the patella down, and you're going to strap that patella down.
Okay. Is that normally pretty painful that you should warn the patient about before you do it?
Oh yeah, you can tell them it's painful, but if you're getting so heavy-handed that they're shrieking in pain, it's too much. So you want to feel it out. You just get on there and they'd say this can be real tender and just squeeze it, because you'll squeeze it and it'll dissipate the fluid underneath of that fracture, push that out of there, and it'll kind of stick it back down in there. And you strap it, and then you bring them back and you do it again. And even after the first one, the pain will start to drop.
Okay. And
Yeah.
you do it more. You said you do it more than once normally. How many times would you do it in the same visit?
Once.
Oh, just once in the same.
Just once. Yep. This is not like pumping a disc. You just squeeze it. You might feel it a little bit and say, okay, I'm gonna give you a little more, and then maybe that kind of a deal. But you're not trying to pump it and pump it and pump it. You just approximate it down and then set it gentle, and then strap that thing down.
All right. Thank you.
Calcium lactate, Cataplex F, almost always will maximize healing for any kind of fracture. One of the other main misalignments of the knee is superior patella. The patella will get stuck superiorly fixated from tight quads, and then you'll get fibrotic adhesions. And so what you do when they're in that loose pack position, when you're palpating them, you get your fingers above that and you start to stretch that down and stretch it down. And it'll be tender, so don't get crazy. And the more you work that down, then eventually what it'll do is it'll give. And all of a sudden you'll feel it slide. And so you always check the patella, move it laterally, medially. There should be nice wiggle there. And then if you get on top of it and set it down, stretch it down, you should feel that thing slide real nice. And if it doesn't, you just, every time they come in, you just set that thing down. You can also come on top of it with a piezoform contact.
Is that something you would tape as well? The first couple of visits to help it set?
Patella, yeah, you sure can. Yep. I don't always. I depending on the knees, I do a lot of taping. I'll tape knees and ankles all the time. I'll do some taping with the shoulder once in a while. I like kinesio tape for the shoulder once in a while. I don't like kinesio tape at all down in the ankle or knee though. But Elasticon from Johnson & Johnson is fantastic.
Okay, thank you.
Rotation listing for the tibia PEX, like I told you, that's the most common. The tibial shaft line will fall laterally to the femur shaft line. The tibia is rotated posterior, narrow on the lateral aspect. The AEX tibia, if the tibia shaft line falls medially to the femur shaft line, the tibia is rotated anterior and wider on the lateral aspect. Use all the tools you got. So here's some drawings. AIN femur, you got the open wedge on the medial aspect. The femur shaft line here, we put a dot in the middle of the femur shaft and a dot in the middle of the patella. Sometimes you got to move this dot that's in the middle of the patella. If you get the patella that is stuck real superior and lateral, you may have to look at the femur in relation to where it's at with the intercondylar gap here. But for the most part, use the patella. But you can see that this line has been pushed laterally. So what does that is the internal side of the femur has rotated anterior or towards me, and that's what pushes this lateral in relation to the tibial shaft line. Questions on that?
I have a question about the AEX and PEX femur ones. Is that just for listing, or would you still contact the tibia when you adjust it?
No. So if you're listing, what this is showing is you can have an AEX femur, and in that instance, you would adjust the femur.
Okay.
Yes. So here you're on the lateral aspect, and in rare instances, and I can't tell you if I've had an AEX femur, but I've definitely had AIN tibias on the medial aspect, not the femur. So that's where you just got to be aware if something's not responding, you may need to rethink through. That's where you get that single probe out and go, okay, let me study this a little bit and see if this really is a knee problem or what's up.
So what tells you to be on the femur for the EX part? What would tell you to be the femur?
Like this one down here you're asking?
Yeah, since it's the wedges on the lateral side. Like what would make you think femur here?
Well, the honest answer is the external tibia is not fixing it. And honest to goodness, it's almost always the tibia out there.
Mm-hmm. Mm-hmm. That makes sense. Thank you.
That's the best I can tell you there. The other thing to keep in mind with extremities too, you might have something like an AIN femur. Anytime you're looking at an extremity, do not forget to check the other end of the bone. So for the femur, for example, the other end would be up in the acetabulum. Or a tibia, don't forget to check the ankle. Humerus, if you got an elbow problem, don't forget to check the glenohumeral joint, the shoulder. Always look at the other end of the joint. Even though the elbow's hurting, it may be the shoulder you need to fix. Here's an EX right tibia, open wedge on the outside. And I would even put a P on this one. This is a PEX tibia. You can see the line there. And the tibia on the external side has rotated posteriorly. And that drug the tibial shaft line laterally. Now, all things being equal, when we're looking through these listings, like Sophia asked, and correctly so, the way you're going to figure out what's going on here, and just like whoever's asking about the AEX femur, what you would do is you would palpate both of these joints. So when I've got that patient sitting in the chair, I'll take and I'll hold the tibia with my inferior hand, and I'll take the superior hand. And so if I challenge and I know the problem's on the external portion, then I'll take the knee and I'll rotate the femur posteriorly, and then I'll check it, and rotate the femur anteriorly, and then I'll check it. And then same thing with the tibia. You'll find one of those is worse than the other. So with the AEX femur that they were just asking about, when you take the femur and rotate it anteriorly, that shouldn't be too much of an issue. But if you try to rotate it posterior and then check there, you'll find that's the stuck spot. And that's how you'll figure that out when you're checking it. And the reason I say you're not going to run into that much is because you don't, not that listing. Now the AIN tibia, you'll run into that quite a little bit. So you got to watch that with the AIN femur. PEX tibia, you'll find a bunch of those. AEX tibia, you'll find a good handful of them. Posterior tibia, you'll find a bunch of those. So go with your pain points. Now the nice thing about the knee x-ray is it will confirm what you're thinking. Just like on the patient, when you visualize an external ilium, you watch him walk, you lay him down, you're like, okay, that's external. It's tender here, my break's there. Then you take the x-ray and it says external, you're like, beautiful, fix it. On the knee, I have had some patients that have had different types of problems in the knee. I had one guy had a bunch of holes in his knees. It was a calcified medullary infarct. I thought for sure the guy had cancer, but it was actually a normal finding. And then you can take note on the degenerative changes of the knee. So what's the classic thing with a person that's got a knee problem? They go to the surgeon. Surgeon takes an x-ray, says your knee's shot, you're going to need a knee replacement, right? You go to the Ford dealer. What's the Ford dealer tell you?
Car's short.
Say that again.
Your car is short. You need a new one.
What kind of a new one?
The newest one.
The newest one, what? You're at the Ford dealer.
Ford.
He's going to sell you a Ford.
Oh, yeah. Sorry.
Right? So Dr. Troxel used to say, he had this patient come in one time. He loved telling this story. He says, well, I didn't remember what the hell the problem was. His knee or whatever it was, but back. So he goes into the orthopedic. The orthopedic goes through, does all their imaging. So he goes back for his report. And I think he was thinking about coming to CT, something to that effect. And so he says, basically what happened was I went in there and I'm sitting there waiting to see the surgeon. And so I'm sitting there thinking to myself, I'm going to have a surgeon look at this. What do surgeons do? Surgeons surge. Oh my gosh, surgeons surge. I don't want to do that. So he goes up to the front desk and he says, hey, I'm so-and-so. I'm supposed to see Dr. So-and-so. Does it cost me anything if I cancel that appointment? And they said, nope. And he says, okay, cancel my appointment. Have a good day. And out the door he goes. And so then he went to CT to get fixed up. And the point is like we started the thing, there's a place for surgeons. There's a place for everybody in healthcare. But there's a huge place for chiropractors. And when T told me, you're getting into chiropractic, you're in sales, I about had heart failure. This is the last thing I'd like. No, I'm not in sales. That's not what I'm here for. But what he was talking about is you have to teach people what it is that we offer. And so when you're teaching them about what spinal care is and what chiropractic care is, that gives them the ability to make a decision and say, you know what? Do I want to buy a Ford or do I want to buy a Chevy? Do I want to have chiropractic as part of my life or don't I? And it's not that it's chiropractic or surgery. That's not the point. The point is you have to teach them what chiropractic is so that it can at least be part of their life to help them be and do the things that they need to do. That's really all we're doing. You will not keep all your patients out of surgery, so don't try. That's not your effort. Your effort is to keep them as subluxation free as you can and guide them in making good healthcare decisions. That's what it means to be a doctor of chiropractic. So we look at these knee x-rays. This one here, for example, anybody pick up on this yet? What's that? This guy had an ACL rupture. This is part of the procedure when they go in there and they sew that thing back together. First thing we're going to do is put a dot in the middle of the femur shaft, dot in the middle of the patella. Same thing on this side. Here you can see the left marker. This is the left knee. This is the right knee. One space to take note of is the space between the tibia and the fibula. As that tibia rotates posteriorly, it will decrease the amount of space. As it rotates anteriorly, you'll see more of that space. So here's your looking from A to P. Watch the space here. As I turn that posterior on that side, see how the space disappears? Now as I rotate that towards you, see how you can see more of the space? That's when the tibia rotates anteriorly. So I just take note of that. So if I was just going to look at this, I'd say, well, this person's got an AEX tibia over here or a PEX tibia over here. They may or may not, but that's just one thing I look at. Now we're going to connect the dots with a line. We're going to drop that line all the way through. Same thing down here, TSL, tibia shaft line, FSL, femur shaft line. And then we're going to take note. So here I said this looks like an AEX tibia, but this line would say if the tibia is listed, it's actually gone posterior on that side because it's lateral to the femur shaft line. This one here, kind of a mute finding. There's not a lot of difference there. But if you were going to list it, it is just a little bit posterior on that side. Now you may palpate that and determine something different, but that's what the X-ray is telling us. Now we're going to dot like points on the femur and on the plateau of the tibia. We're going to run lines through there, and then what we're going to do is we're going to look to see which side they diverge. And you can see in this X-ray, they both diverge laterally on both knees. Even before we put the dots and draw the lines, you can see that this space here is not the same height as this space here. Same thing here. This one's even a little thinner and a little wider. So when we put the lines on there, that just exaggerates that for us. Now the rule is if the lines diverge laterally, we're going to list the tibia. If they diverge medially, you're going to list the femur. Interestingly, the one that we fix the most is the AIN femur. Guess where we see most divergence of the lines over time? Laterally. Reason being is the medial meniscus is the one that degenerates quickest over time. So there we list it. I put a small p, EX, and on this side, there's a small AEX. I don't like that listing. We'll have to redo that one. That should be, if anything, a small PEX on this side too. But definitely both external. Here's some really bad knees. Marcus, what listing would you give to there's no marker on this one either, left knee here?
That would have to be an AEX tibia.
Yep, based on the way this looks. And then on this side?
That would be also an AEX.
Correct. Now, you were asking about sideline versus adjusting sitting in the chair. This person will for sure do better sideline. My dad's got a knee like this, and he does really well with it. And I always adjust the external side when he comes in. These types of people will not respond as well if you adjust them in the chair.
And why is that? Is that just because it's better line of drive to get through that disc space?
Well, because when you take this block and then you put that, then you put that right here. So the bottom of the block would be here and the rest of it would lay like this. Then you put that on the bench. That is very solid. So now I can hold his foot and set my pisiform right here, and I can set that up and through that joint, and this doesn't move at all. I can really change the relationship of that soft tissue much better. Even if I've got an intern that comes and holds here, when they're sitting in the chair, there still tends to be some motion of the leg as I'm pushing into here. It's just so much more stable.
And just to clarify again, we want to stabilize the femur on a tibia adjustment. We don't want to stabilize just the other side on both sides, right? Or do you want to stabilize both the tibia and the femur on the opposite side?
So right here, this meniscus and tibia this is where my pisiform would be. I'm going to grab the meniscus and the tibia, and I'm going to set. We always talk about take the disc with a tibia adjustment. So I'm going to set my pisiform, my fleshy pisiform, so I'm holding here and this disc actually, and I'm going to set that this direction. My block is only going to stabilize. We want to just stabilize just the femur, not the meniscus, if there was any meniscus in this case.
No, for sure. Because I feel like sometimes I think I'm probably being sloppy with my stabilization. I'm actually working against myself because I'm also touching the tibia. So
yes, absolutely, absolutely. That's a bingo right there. And this would be a tough one. You got to really palpate that smart. So if I'm stabilizing a femur, if I'm not sure, I can even cheat that block up here a little bit and still actually get really good stability. Now, if you had to adjust this femur and you needed to stabilize here, you would not want your block down in here, because now as you push that femur this way, you're going to squish that disc further out. You want that block to be right here best you can. So take your time to palpate and you hold that meniscus. That's the main thing I got to do when the interns stabilize for me, because they're like, oh, stabilize the outside of the knee. Well, if they're stabilizing both sides, then in this instance, it may be okay. But if they get down here and stabilize the disc and the tibia, then I can set the femur across.
Thank you.
Honest to God, what you're asking there and what we're talking, that's 90% of what you're doing with the knees. The other 10% is the posterior tibia. They're such a simple joint. They're fabulous. Here's some more listing examples. Like I said, I'll send the PDF of this through to Macy, and she can send it to the group here, okay? So here's an example of an AEX tibia. The tibia shaft line is deviated medially compared to the femur shaft line, open wedge on the outside. This one, again, I would love to set this, sideline. Tibia shaft line here. Did we put a listing on that one? Well, same thing, AEX tibia. Oh, that's the same knee. All right, adjusting the AIN femur. We're going to wrap it up here, gang. I got to get moving here pretty soon. The patient should be sitting in a chair with the upper half of the thighs supported with the chair. The doctor would be sitting in front, medially to the knee being adjusted with the fingers pointing down. Contact the anterior medial aspect of the medial condyle of the femur with your fleshy pisiform of the superior hand. The stabilization hand should support the ankle and rotate it medially to help take out the anterior rotation misalignment of the femur. Flex the knee slightly and give a thrust A to P with torque medial to lateral. The thrust is at 45 degrees unless it is subluxation at more A to P medial to lateral angles. Find the sweet spot when you're adjusting. Locate that spot with your palpation. Usually static is where you're going to find that, and then the motion palpation will really hone it in. Rotate the leg, play with knee flexion. So sometimes you need to be a little bit more flexed or a little bit more in a flat position. You'll find a spot right in there where it's like, okay, there's where it's stuck. That's where you set it. Elbow angle, arc, arc, arc. Good hurt or bad hurt? Good hurt, we don't mind. You lean into it, they're like, oh, that hurts so good. Hold that pressure and just give it a little bump. Bad hurt, they wince and they're like climbing out of the chair. Something's wrong, your angle's off. Use the most common sense approach. So there's an AIN femur contacting the medial condyle. Here the stabilization is contacting the PEX, so the fingers come up, and they're contacting the tibia and the disc. That's sitting in the chair there, obviously. You could do that same thing side lying. This person would lay on their left side. The block then would be where Gigi's hand is at here. And I would hold that leg and contact it just like what you see there. Not going to go through the PIN femur, but there would be the setup. Now, if I do this myself sitting in the chair, this is what it'll look like. There's a little bend in the knee. I'm controlling the whole leg, so I don't hold the ankle to rotate. I will actually put my elbow on the distal end of the leg here, and I'll hold the tibia right here, and I'll turn the whole leg with this hand right here. Here I'm contacting the posterior aspect of the femur because it's a PIN femur. My finger, I try best I can to just put a finger on the tibia and that lateral meniscus. If I was going to contact the tibia here, then I do the opposite. I put a finger over here to hold and stabilize that femur best I can if I got to work by myself. Here you can see Doc doing a PIN or an AIN femur. Adjusting the PX tibia. Position the patient as the femur adjustment with the doctor sitting in the external or lateral side bend of the bad knee. With the fingers pointing up, contact the posterior lateral aspect of the tibia, including the meniscus, with a fleshy pisiform. Stabilized hand rotates the leg medialward. That's to take the posterior rotation out. Thrust is lateral to medial, P to A, with a quick set, but not terribly deep. You just got to take the slack out and then set it. Once in a while, you'll get an audible with an external tibia, sometimes with a posterior tibia. AEX tibia, contact the anterior portion. So here's PX tibia. Again, I'm trying to hold the medial aspect of the femur here. There's with someone else stabilizing for me on the femur. Now I've got my hand down there controlling the ankle. There's its sideline. There's the AEX sideline. I'm going to show you a few videos here to end this so you guys can see them. And I'll upload those to Dropbox. I'll send that link to Macy too so you got them. Adjusting the posterior tibia. Posterior tibia cannot be seen on X-ray. Patient's symptoms and palpatory findings will determine the posterior tibia. Once in a while, you can actually see it on X-ray, but not generally. Swelling behind the knee, that's a big one. Baker's cyst. Baker's cyst says posterior tibia, please come fix me. Pain is usually behind the knee. Sometimes you'll find it under the kneecap too, though. So that'd be the anterior mimicking a patella subluxation. With the patient prone and the knee flexed to 90 degrees, contact is made with both hands thrusting S to I. Make a note here. 90 degrees could be as low as 30 degrees. Sometimes you got to, instead of having that knee up, you got to bring it way down, and that's where you set the tibia. Up and in with the tibia. It's not a pull. It's down into the table. So we're not bending the knee. We're not bending the knee like this and then yanking. We're contacting the posterior aspect of the tibia and grabbing that disc with the knife edge of our finger. And then we're going to set it back P to A. So it's this into the table. The table stabilizes the femur. We're setting the tibia back forward. We're not just pulling on it. That's the main error that I see with posterior tibias. Could you see what I was trying to demonstrate there good enough?
Yes, thank you.
So we're not yanking the knee S to I. You distract S to I a little bit to open the joint so there's a place for the bone to move, but then the hands are setting that in an arcing fashion, almost like an AS occiput would be a way to think about it, but you're setting that back into the table. That's how you correct the posterior tibia. Patella may slide superior and fixate in that position. We already talked about this. The lateral film will reveal raised patella and spur formation behind the bone. Normally the apex of the inferior border of the patella is at the level of the joint space. That's a good one to look at when you're looking at these knee X-rays. So here's the inferior patella. There's the joint space. Now here's your superior patella. See it? Bottom of the patella is here. Joint space is way down there. That's a superior patella. That's the one that we talked about working that down. And you'd be surprised how much relief that will take off of a knee. Check your, especially Asian patients that still do a lot of Indian style sitting. All of them have knee problems and pelvis problems. Here's what that looks like on an X-ray. You can see how superior it's sitting. Joint space is down here. So you're getting a lot of rubbing through here, spur buildup back there. You start working that patella down and you'll be Superman. So in this picture here, I'm just working that down with my thumb, and you just start working it down because it can be real tender. And it may take you 2 or 3 visits before that thing finally releases and slides down the way that it should. Here you can see Dr. Roger using a web of his thumb to push that S to I. And the patella is actually something you can teach your patient to do too. They can push that down when they're at home. All right, posterior lateral fibula. Lateral aspect, hold the foot down here, and you set that back P to A. The big thing with the fibula is you're going to have pain. Sounds good for that. You're going to have pain right over that joint. So anytime you're evaluating the knee, always drop down to the fibula here and just palpate around it. The main direction that it goes is posterior and lateral. Sometimes it can go posterior and medial.
Doc, for that fibula, are you going lateral to medial lever?
So if it goes posterior and lateral,
yeah,
you're going to contact on the posterior aspect, and you're going to squeeze it back P to A and back into the tibia.
Okay.
That's all it is. It's the simplest adjustment you ever do. Once in a while it'll slide medial, but not very often. It's usually posterior lateral. So there's a little bit of lateral to medial just in the way that you contact it. So if I give you an angle, it's mostly P to A, and as you bring it P to A, it'll usually slide back into the tibia. If you get that, definitely check the other end of that bone, because if it goes posterior and lateral there, a lot of times it's posterior at the distal end at the foot, and that occurs a lot with an ankle sprain. If you read in the last chapter with extremities and it talks about ankle sprains, the posterior tibia at the distal, or fibula at the distal end, is part of an ankle sprain. So when you're fixing the bad ankle, it's always calcaneus, talus, that kind of deal, but don't forget the fibula.
Thank you.
All right, we'll finish up right here. Here's an AIN femur sitting in the chair.
Right now, isn't it?
So you're gonna come. Oh, just stay around that side. This is Gigi, my front desk gal, so she don't usually stabilize knees. It's usually my interns.
Down a little bit, actually. You can go way down. Squat down a little bit.
Oh.
There, hold right there like that.
Gotcha.
Just right there.
That's my nephew, Aiden.
This is a good problem. Like that. Good. Thank you, Ian.
So that's a pretty common procedure there, Marcus. When you're asking about setting the Osgood Slaughter down, you can do a few little bumps like what I did there, but generally on a hot Osgood Slaughter, they're going to give you one nice set and then strap it. But with an extremity, I don't mind at all just kind of working into the adjustment, feeling it out, and going, okay, right there, give it a little bit more if you think you need it, versus just trying to set it and then wish you had done less. You can always do more. Just like we talk about with the spine, work yourself into a situation. And Dr. Gonstead's famous quote was always, the older I get, the less bones I adjust and the less hard I adjust them.
So you're going to come. Oh, just stay around. So you can go way down. Squat down a little bit.
Oh.
There, hold right there like that.
Gotcha.
So right there, I'm placing her pisiform on the lateral aspect of the tibia and the meniscus. So now that I know she's got that, you can see the stress. There's my spot. So what I was palpating for there, Sophia, was the spot that I found when I evaluated her. So when I was working through that meniscus, I found the spot. I went back and refound that with my thumb, and now I'm putting my pisiform right on that spot. That's the spot you want.
This is a good problem.
I took her foot and I'm turning it medially to help fix the anterior portion of the femur. And that stress I'm pushing in, I'm setting at an arc up in through the joint, and she is just holding that stable. And this is pretty good here. I don't have any issues with this. There you go.
Thank you.
Here's superior patella.
This knee here, he's got both knees, pretty severe EX tibias, which we just adjusted. But I'm going to show you the patella portion of this. When I try to grab a hold of this patella and pull it down, it is like a rock. And you can tell you that thing don't move at all. So I'm not going to force it too much today. But at some point, this thing's going to start to let loose and come down. And that's going to take a lot.
So what I was just doing there, that literally was the adjustment that I'll do to get something started. Now, sometimes, like this guy is a newer patient, so he'll be back in a couple of days, and I'll do it again. Now, if I had one where I may not see him for a while, I may work that for five minutes or so, have him go walk for a half hour, and then come back and do it again. But basically what you're doing is you're breaking up adhesions in scar tissue that's got that thing stuck up in there. It's the patella is not a true joint, if you will. It's embedded in the muscular tissue and the fibrous tissue that ties into the tibia that makes the leg go like that. It works as a fulcrum, as you guys know, in a pulley system. But you're just working and breaking those adhesions apart.
Stress off of his knee as well as his low back. When I checked this one here, which he had an ACL tear on a long time ago, I checked that knee, and that patella's.
This is the posture that I was talking about. This is a really good way to assess a patient's knee. That's probably the best.
Right down.
See how that patella falls?
A good half inch. He can tell you he can feel that. And if I go side to side, it's got some wiggle in there. You can see the swelling here. That's part of the posterior tibia. All right. You do real good. That's going to take.
So all I was doing there is I was working myself around that meniscus on both sides, and I was just stressing it at different spots just to see what things felt like there. And each time the patient comes in, you get your hands on them until you get everything figured out just the way you want, and that's the spot you'll work. And then as you work with it, it will change. That's what you want. So just because you're fixing an AIN femur today does not mean you're going to fix an AIN femur forever. Some people, that's the way it'll present, but other people, you get that good, and you may not touch it for 2 or 3 years. Next person comes through, same deal, and they need it bumped once a month for the next 2 years, and then it's better. So that's why you always check them, and you decide what does or doesn't need to be adjusted, or if you need to change something.
Block right under there and stabilize the femur. And the joint space here.
PX tibia.
Check the rotation just to double check. This one's got a small amount of P in it. Take that out at the ankle. Contact P to A. Like that. I'm going to set it up and in. There's my lean on it. Nice and reset. Okay, let's lay the other way here, Steve.
So, Doc, how do you know normally when you're going to good adjust? Like, it's not going to make too much noise, or are you repalpating that motion normally to see if you got most, or are you doing it a few times and then say that's enough for the day, despite it?
So now I do that one. If I get what I want and I can feel that I got into the joint the way I wanted to get into it, that's all I'm after. The best post scope is best post check is either to scope or visualize. Let them walk. So a lot of times you work on a knee or something like that. Get them up and just let them walk for a couple paces, and you'd be surprised when you're on that right spot. 9 out of 10 times they're going to go, "Oh, that feels better." Just be done. Dr. Phyllis did not like, she said Dr. Gonstead did not like a lot of palpation after an adjustment. She said, leave it alone. But that's hard to do because after you do something, you want to go in there and feel, did I change it? So I still do it. Almost all doctors will. They'll go palpate something like, oh, that's a little better. But the further you go, you'll start to trust, one, how it felt under your hand. And you'll be like, nope, I know what I was after. I know that moved the way I wanted it to. I'm just going to see what it looks like next time. That just takes, some experience, and it'll come. And sometimes you're just going to have to go, you know what, that was good. And trust yourself, and then let them come back next time and just make a note and go, okay, I didn't look at that last time. I want to see what it looks like today, because that is your best post check, is the next time you see them. Once you start seeing them on consecutive visits and things are improving, now you know you're on the right track. You can do a number of different things with a patient and have them feel better within 5 minutes leaving the office. That's got nothing to do with correcting a problem.
Thank you.
All right, Carol. I'm going to check those 2 spots again. Tender there at all?
No.
How about there?
Yeah.
Okay.
Here's your posterior lateral
What do we call
fibula,
this?
Marcus. There's the posterior lateral
Posterior
aspect
lateral.
right there.
I'm just going to compare to the other side here. Carol had a fall.
There's a note I forgot. Always compare extremities to the other side. Always, always, always.
So the only thing I'm recording here, Carol, is just a close-up on this spot. Had a fall 3-4 weeks ago, and so Brittany's been putting her back together. So I'm going to use a fleshy piezoform contact here. And when I set this, I'm going to set it P to A, slightly I to S, but lateral to medial. I'm just going to set the fibula back to the tibia. So we're going to bring this up here. One more. There you go. And now there's more give when I just do a P to A, lateral to medial. Just a little bit of palpation statically like that. You can feel that there's better motion there. That hurt you real bad, Carol?
No.
A little tender, wasn't it?
A little bit.
Yeah.
Not horrible.
Okay. Thank you very much.
That was one of Dr. Brittany's patients snuck in and saw me when she was gone. Last one, posterior tibia. Now, ideally, always skin on skin.
On the left posterior tibia. Just a gentle P to A pressure, and you can feel right here. This one doesn't want to squeeze.
Anyone know the number one symptom in their daily life for a posterior tibia? Patient reports it hurts when they go downstairs. When they go downstairs, posterior tibia.
Then you're like the right. Bend that up. This one bends up a whole lot easier.
See how much further the one on the right went? So when you bend that knee up, a posterior tibia will not go as far as a normal tibia.
Right here. This one doesn't want to squeeze in. You're like the right. Bend that up. This one bends up a whole lot easier. So we're going to take a simple knife edge contact here. We're going to come down in the posterior aspect. There's going to be an I to S tissue pull and roll in up into the joint. We want to contact up and in as high as we can in the backside of that meniscus. And she'll tend to tell you that's a little tender in there. So I'm going to bring this right in here with this left finger. I'm going to come right in behind it. I'm going to bring her foot up on my shoulder. I'm going to retake that tissue pull, and I'm going to test where that's most stuck. So I can bring her leg down a little bit, and bring it up a little bit. Right there's where it's most stuck. There's not a lot of rotation on this one. It's mostly straight posterior. So I'm going to work way down in there. Now I'm going to distract this direction just a little, but not a lot. So I'm just going to open the joint up a little bit. From there, I'm going to rock my hands and pivot them up and in, down into the table. One more here. And once you get it set the way you want, with a quick set, you hold it and gently let that down. And that's all there is to it.
Questions, gang? You guys all look sleepy.
Oh, sorry, I was talking with the mic on mute. But that was really cool to see, and that posterior tibia is not at all what they really describe it as. What we, it's more just a pull, like you said, but the way that we're kind of taught it. So this is a much more controlled way, for sure.
Anybody else got any questions or thoughts? Are you awake, Macy?
I'm awake.
Well, I will send Macy an email. I'll put a link on there for the notes she can get to you guys, and
Cool.
just keep up the great work down there.
Thank you, Dr. Lawlor. And we're going to come see you in November. We have a group already. We're up to about 19 that are guaranteed to come. So
Awesome.
Nice group up there, and we're excited to see you guys and get around that awesome atmosphere again.
Cool. We'll have the lights on for you, buddy.
Yes, sir. Well, thank you again for everything and donating your time again after practice and everything that you do. We truly appreciate it.
Yeah, you guys are doing great. I appreciate you guys.
Thanks, Dr.
Thanks,
Lawlor.
See you guys.
Thank
See you guys later.